Okay, so welcome everyone to the Usmle Step 1 lecture by Dr. Haidari for batch 3. That is reproductive lecture number 6. Thank you so much for joining the lecture. Hope you guys are doing well. If you guys can hear my voice, can I please get a yes in the chat box? Can everyone hear my voice? Yes or no? Okay, good. So thank you so much for joining the lecture. Today we are going to discuss breast pathologies. But before we discuss breast pathologies, I just want to talk a little bit about the uterine conditions that we talked yesterday. Very quickly, I just want to let you guys know that the uterine conditions, the ones which are very high yield, the ones which are not high yield. And in all honesty, every one of these uterine conditions are very, very high yield, okay? So before I move on to breast pathologies over here, can I ask a couple of quick questions and see if you guys remember the uterine conditions and then move forward, yes or no? Fast answers, please. Can I ask a couple of very quick questions regarding uterine conditions and then, yes? Okay. Is everyone ready? Yes or no? Okay, good. First one, abnormal uterine bleeding, that is menorrhagia, metorrhagia, with enlarged, boggy uterus. What is your diagnosis? Enlarged, boggy, uniform uterus. What is your diagnosis? Adenomyosis. Very good. Abnormal uterine bleeding, menorrhagia, metorrhagia, with history of multiple DNC and PID, not PID, history of DNC and abortion, Asherman syndrome. Abnormal uterine bleeding, menorrhagia, metorrhagia, with normal size uterus, abdominal pain, adnexal mass. Endometriosis, very good. Abnormal uterine bleeding, menorrhagia, metorrhagia, with fever, pus, endometritis. Abnormal uterine bleeding, post-menopausal women, estrogen, hormone replacement therapy use. Endometrial hyperplasia, very good. Abnormal uterine bleeding, postmenopausal woman with estrogen, hormone replacement therapy, weight loss. Carcinoma. Abnormal uterine bleeding, menorrhagia, metorrhagia, with irregular enlargement of uterus. What is your diagnosis? Irregular enlargement, not fibroma. This is fibroid. Very good. Fibroid, no problem. Thank you so much. Okay. So very quickly, let's just underline the breast, the uterine pathologies over here. Just give me 1 second. So I'm just gonna let you guys know very quickly which uterine conditions are very, very high yield. Now, please have your red pen to give a star beside adenomyosis, give a star beside endometriosis, endometrial hyperplasia, endometrial carcinoma, and fibroid. Okay, so adenomyosis, endometrial hyperplasia, endometriosis, endometrial carcinoma, fibroid. Have I made myself clear? Yes or no? Yes. Okay. Okay, good. Now, are we ready to begin the breast pathologies? Is everyone ready? Yes or no? Is everyone ready to start the breast pathologies? Yes or no? Okay, Dr. Noon Mohammed is ready. Is everyone else ready? Yes or no? Okay. So let's begin with breast pathology. Now, before I talk about the different pathologies of the breast, let me just quickly talk to you guys about the breast physiology, all right? So the breast physiology is basically, if the breast physiology is basically, if this is the lateral view of the female breast, right? And if we were to have, for example, let's say that if this is the frontal view of the female breast, and if I were to do a coronal section like this, right? And if I were to view the structures, then how would they appear? Okay, then the structures would appear like this. So this is the opening of the breast. Okay, the breast opening is at the nipple and at the areolar area. After that, we have a duct, which is used for collection of the mammary gland secretions. Then after one duct, we have another duct that will go back all the way. And then we have another terminal duct that ends in this flower-shaped or finger-like projection manner. Okay, very quickly. So what we have from all of this is that over here we have a lining that goes like this. Okay, so that's that. Now this is the this duct over here. Okay. This duct over here, this is known as the lactiferous duct. Okay. Okay, so this is the lactiferous duct. Then over here you have the major duct. And then over here you have the terminal duct. So you have three ducts. Okay. It's really important for us to know what sort of a duct we have, because different sorts of pathologies can arise from different portions of the ducts. That's it. And this portion over here, okay, this entire portion over here that is lining the ducts, these areas, they are known as the stroma. Stuff like that. Okay. Now, the thing is, we have breast pathologies in terms of benign breast diseases and malignant breast diseases. Okay. Now, there's a question in your step one exam that where do we have the different sorts of diseases arising from? Okay. So the different diseases that arises, for example, if this is the lactiferous duct, if this is the major duct, and the green is for the terminal duct. From the lactiferous duct, right? Lactiferous duct is the area that is closest to the opening of the breast, right? So this is the area where patients are more likely to have mastitis or breast abscess. This is because if there was any duct that would be infected or inflamed, it would be the first duct, right? So mastitis and abscess are very common in the lactiferous duct. Then the next thing that is very common over here is intraductal papilloma, which is a benign breast condition where we have bleeding from the breast. Another one is not a benign condition. This is Paget's disease. Okay. So mastitis, abscess, and intraductal papilloma, all of them, they come from the lactiferous duct. And some of these conditions also arises a little bit. If they extend backwards, then can they go and infiltrate the major duct? Yes or no? Last chances, please. The answer is. If these conditions infiltrate backward, can they affect the major duct? Yes or no? The answer is yes. So sometimes the major duct can also get infiltrated with mastitis, intraductal papilloma, and Paget's disease. The green area is for the terminal duct lobular unit, right? And in the terminal duct lobular unit, we get majority of our carcinomas. That is, we get ductal carcinoma, lobular carcinoma, and we get one benign condition known as fibrocystic changes. Okay. And from this portion over here, this portion of the stroma, we get one condition that is known as phyllodes tumor. Phyllodes tumor. Now, why am I taking some time to explain to you guys what is the location of each of these diseases? The answer is because which duct is important for what sort of disease is a very high yield question for Usmle step 1 exam. Meaning that this picture over here, this picture that you have in the first stage, this picture is a very, very high yield picture. So I need you guys to put a star mark for over here. The one that I drew is the exact picture of this one over here. As simple as that. Okay. Did we make, is everyone clear? Yes or no? Is everyone clear? Okay. Can I get some feedback in the chat box, please? Is everyone clear or not? Yes or no? Okay, good. Next one is, let's jump into the text. So we have benign diseases and then we have malignant diseases. Let's talk about the benign diseases. Now, I need you guys to understand something very, very clearly. That is, when I talk about benign breast diseases, majority of students, they have a very big difficulty in differentiating fibroadenoma and fibrocystic changes. This is something which a lot of students, they have problems with understanding. Now, fibroadenoma and fibrocystic changes, these are the two first benign breast conditions which I want to talk about. Now, fibroadenoma and fibrocystic changes, what are they? So before I begin, let me just figure this out very quickly. Okay. First and foremost, what is fibroadenoma? Fibroadenomas, these are basically well-defined mobile breast tumors that are benign, completely benign. Now, if they are benign, then shouldn't they also have the factors and properties of a benign tumor? Yes or no? The answer is yes, right? What are the properties of a benign growth or a benign tumor? First and foremost, will they be smooth? The answer is yes. Will they be regular? The answer is yes. Will they be capsulated? Yes or no? The answer is okay. Yes, very good. Then will they be capsulated? The answer is yes. Will they invade the surrounding blood vessels and the surrounding structures? Yes or no? The answer is no, right? And then what else? Will they have excessive growth? Yes or no? The answer is no, right? So these are the properties of a benign growth or a benign tumor. So fibroadenoma is the most common benign tumor. So fibroadenoma and fibrocystic changes. Fibroadenoma, if I talk about the tumor, then fibroadenoma is very common. And fibroadenoma is common, and fibroadenoma is a tumor that is small. It is either unilateral, meaning that it's usually the number of fibroadenomas that we usually get in patients is usually one. We do not get multiple fibroadenomas. Then these are very common premenopausal women, but so are fibrocystic changes. So that's not really something that I'm going to use. And another thing over here is that you get over here, patients, there is a possibility that they also get increase of size and tenderness and everything else. But the thing is, what is the risk of cancer? Is it high or is it low? The answer is risk of cancer is very low, almost not being there. Now, what are fibrocystic changes? Fibrocystic changes, they are also very common, right? They're also very common in premenopausal women. And the thing is that over here, fibrocystic changes are benign tumors, but they are not uniform. They are not regular, meaning that they are common. They are not regular. fibroadenomas, they are regular, uniform, and smooth. They are lumpy. Okay, they are lumpy. And another thing is fibroadenoma is usually unilateral. Fibrocystic changes are bilateral or multiple. We usually get multiple bumpy structures in the breast, right? And over here, the fibroadenoma is basically not as small. It's actually bigger than the fibrocystic changes are actually bigger than fibroadenoma. And another thing is the risk of cancer also in fibrocystic changes are very low. Okay. Now, Usmle step 1 usually makes question based on your information of the number of lesions. Always remember this. If you're ever confused between fibroadenoma and fibrocystic changes in your Usmle step 1 exam, look at the number of the lesion. If they say that it's a one uniform lesion that is small, that is mobile, right? It is associated with premenstrual breast pain. Your answer is fibroadenoma. If they say that the lesions are multiple, bilateral, irregular, right, and there are premenstrual breast pain and everything else, then the answer is fibrocystic changes. Have I made myself clear? Yes or no? Fast answers, please. Yes. Okay, good. Now let's talk about the benign breast diseases. Now, since we have addressed the important question, now let's talk about fibrocystic changes a little bit in details. This is most common in premenopausal women. This presents with premenstrual breast pain or lumps. Please underline lumps. They're often bilateral and multifocal, and they are composed of cysts, right? They are composed of cysts. And over here, we can get papillary, apocrine, or stromal fibrosis in the fibrocystic changes, which are not important. You do not need to remember this. It's not important. Risk of cancer is not increased. So that's that. Next one is fibrocystic changes are two types: sclerosing adenosis and epithelial hyperplasia, right? The only thing you have to remember is that out of fibrocystic changes, you have two subtypes, that is sclerosing adenosis and epithelial hyperplasia. The only question you might receive, it's not even a question yet, but there could be a question in the future, that which subtype of fibrocystic changes is more at risk of developing into cancer? The answer is sclerosing adenosis. Okay, so that's the only thing that you have to remember. Sclerosing adenosis is associated with calcification. So there's a slight increased risk for cancer. Very quickly, if sclerosing adenosis is associated with calcification, can anyone tell me, let me see if you guys remember, why do we have the deposition of calcium in sclerosing adenosis, or why do we have depositions of calcium in any breast lesion? Does anyone know? A quick yes or a quick no would do, so that I can move forward. Fast answers, please. A yes or a no. If you do not know, that's completely okay. I'm going to tell you the answer. We can move forward, but please give me an answer so that we can finish the class. Saponification, no. Trauma, no. No. Okay, good. The answer is because sclerosing adenosis is a type of fibrocystic changes where we get partial, very minute necrosis of the breast tissues. What happens whenever we get cellular death? Do we have deposition of calcium in the area of the cellular death? Yes or no? The answer is yes, right? Why do we get depositions of calcium around an area of cellular necrosis or cellular death? Is it because the pH of the tissue increases? Yes or no? After death? The answer is, who remembers that calcium deposits in an alkaline condition? Do you remember, I have stretched this so many times in the past, that calcium deposition is more common in alkaline conditions. For example, if you have to have calcium resorption, right? By what? If you have to have calcium resorption by your cells, do they have to create an acidic condition for the calcium to get resorbed, or do we have to create an alkaline condition? Right? What happens? The osteoclasts, they come to the bone for calcium resorption, and what do? They secrete enzymes such as alkaline phosphatase or acid phosphatase, right? This creates an acidic condition that allows calcium to get mobilized. So this is the only thing you have to remember, that Fibrocystic changes are most common. They are benign, they are bilateral, they are multiple, and there are two subtypes. You have sclerosing adenosis and epithelial hyperplasia. Sclerosing adenosis is increased risk for cancer, that's it. Next one is inflammatory processes. What are some inflammatory processes? You have two types of inflammation that is very high yield, and that's benign. Number one is fat necrosis. Fat necrosis is something that, for example, if females, there's a possibility that they might have received a trauma to their breast, but they did not understand. For example, let's say that the trauma was not excessive enough to cause severe pain, but that small amount of trauma resulted in death of the adipose tissues, right? Necrosis of the fat and the giant cells. So what happens is right after we have necrosis of the fat and the giant cells, do we have deposition of calcium? Yes or no? The answer is yes. Once again, calcified oil cysts are deposited. Now, these type of patients, they will come to you. They will come to you because if they have a very big fat necrosis, then, for example, do females conduct self-breast examinations? Yes or no? That's answer, please. Do females conduct self-breast examination? The answer is yes, right? So there will be some females who will come to your clinic and they will be really concerned because they will let you know that they have an irregular growth in the lateral side. It's usually in the lateral side of their breast. So when you do an ultrasonogram, you see that the growth is calcified growth, right? That the growth is a calcified growth. Now, the thing is, we usually do not do biopsies for these sort of growths, but just to be on the safe side, just to be on the clear side, we will still take a little bit of the tissue, and then we will study this. And under biopsy, we can see necrosis of the fat and giant cells, as simple as that. Okay, so that's basically what it is. Next one is lactational mastitis. What is lactational mastitis? Lactational mastitis is that when mothers, when they are breastfeeding, there's a possibility that there could be a lot of milk accumulation in this lactiferous duct and the major duct. And when this milk accumulates in the lactiferous duct and the major duct, if there is some sort of a skin break, right? For example, let's say that there is some sort of a trauma or the skin around the nipple breaks, then since the area of the nipple is exposed to the baby, there's a possibility that organisms from the baby's mouth can infect the skin, and that organism can spread and they will start colonizing in the stored milk in the lactiferous duct, because the milk is a very fertile ground for growth of the bacteria. Can anyone tell me why? That's because, does the milk contain glucose? Yes or no? Fast answers, please. Glucose, lactose. The answer is yes. Okay. Always remember that organisms, they grow well in a well carbohydrated environment. So since that happens, there's accumulation of these organisms. They grow and they cause inflammation and infection. The most common organism is Staph aureus, Staphylococcus aureus, right? So how do we treat this? This is very simple. First and foremost, if it's a mastitis, then we ask the patients to get rid of the stored milk? Yes or no? If there is unilateral breast engorgement, do we ask the patients to get rid of the stored milk? The answer is yes, right? Because when we ask the patient to get rid of the stored substance in the lactiferous duct, are we getting rid of the bacterial colonization? The answer is yes. That's number one. Number two is we start immediate antibiotic. Do we ask the patient to breastfeed from the same side of the breast or another side of the breast? Fast answer, please. The answer is we ask the patient to breastfeed from the same side or from the opposite side. Which side? Fast answer, please. Can anyone tell me, do we ask the patient to breastfeed from the same side or from the opposite side? Okay, can I get some answers, please? Same side or opposite side? Same, opposite, same, opposite. Okay, good. Now, let me clear this confusion. First and foremost, if it's a mastitis, if the mother is getting rid of the infected breast milk and now the mother is producing normal milk, then the mother is allowed to feed from the same side if needed, no problem. Because if the mother does not feed from the same side, isn't there a possibility that in the future there will be more accumulation of the milk? Yes or no? The answer is yes. Okay. So we ask the mother to do this. But let's say that the mother develops a breast abscess. In that case, do we make sure that the mother changes the side of the breast? Yes or no? The answer is yes. Okay, good. So what happens if the mother develops a breast abscess? First and foremost, do we do incision and drainage of the breast abscess? Yes or no? The answer is yes. After we do incision and drainage, do we flush the area with normal saline with antibiotics? The answer is yes. Do we dress the surgical area every 2 days to make sure that there is growth of normal tissue in the surgical area? Yes or no? The answer is yes. Do we prescribe at-home antibiotics for the patient? Yes or no? The answer is yes. Okay. So treat with antibiotics and continue breastfeeding. As simple as that. I'm not really sure why you guys took so much time to give me the answer. If we should be advising our patients to have breastfeeding from the same breast or the opposite breast, because the answer is right over here. Okay. The answer is right over here. Treat with antibiotics and continue breastfeeding. Okay. Let's move on to benign tumors. Is everyone ready? Let's talk about fibroadenoma. First and foremost, is fibroadenoma small, uniform, encapsulated, mobile? Yes or no? The answer is yes. If it was bilateral, nodular, what would be the answer? Fibrocystic changes or fibroadenoma? Fibrocystic changes. Very good. It's most common in females less than 35 years. It's a small, well-defined mass. It's composed of fibrous tissue and glands and increased size with tenderness and with increase of estrogen. So that the risk of cancer is not there. So that's fibroadenoma. Okay. I talked about this. I'll move forward. What I do want to talk about is intraductal papilloma. Intraductal papillomas are basically papillomatous growth, right? What are papillomas? Can anyone tell me what are papillomas? Papilloma, is this an epithelial metaplasia of the squamous? Papillomas, are they metaplastic changes of the squamous epithelium? Yes or no? The answer is yes, right? Meaning that a papilla and a squamous epithelium, they have the same type of architecture. Yes or no? The answer is yes, right? So intraductal papillomas, they're also considered to be benign growth. The only problem is that due to wear and tear, this is only a hypothesis. The hypothesis suggests that females get intraductal papilloma because of wear and tear of the duct lining. And this wear and tear of the duct lining results in metaplastic change of the epithelium to papillary epithelium, as simple as that. So when that metaplastic changes happen, what happens is, can we get minute rupture of the blood vessels? Yes or no? That are lining the ducts of the breast? The answer is yes or no? The answer is yes, right? So whenever we get minute rupture of blood vessels during the metaplastic changes of the breast, we get bloody or serous nipple discharge. Bloody or serous nipple discharge. And since metaplasia is involved, isn't there a possibility that metaplasia can turn into dysplasia? Yes or no? And that dysplasia can turn into anaplasia? Yes or no? The answer is yes, right? So there is an increased risk, slight risk for cancer. Slight increased risk for cancer. Very quickly, I just want to ask you one very high yield clinical question. If there's a female less than 30 years of age, are we going to perform ultrasonogram or a mammogram to visualize the breast changes? Fast answers, please. Very good. How do you guys know this? Did I tell you this before? Or do you know this because you know this? Did I share this information with you guys before? Yes or no? No, I did not share this. Okay, good. So please write this down over here. Less than 30, ultrasonogram. Then mammogram. First ultrasonogram, then mammogram. More than 30, first mammogram, then ultrasonogram. Have I made myself clear? Yes or no? Okay. Okay, good. Next one is phyllodes tumor. What is phyllodes tumor? Phyllodes tumor is a large mass that can grow in the stroma of the breast. And they're a large mass. They consist of connective tissue. But the thing is, phyllodes tumor, the word phyllodes, okay, look what happens when I write the word phyllodes. Basically, the word phyllodes is word that we use to represent structures such as leaf-like structures. So since phyllodes tumor is a tumor which has lobulations like this, it's a large mass which contains leaf-like, it's a large mass which contains leaf-like lobulations. So this is the mass and these are the lobules, right? So that's why this is known as a phyllodes tumor. In your USMLE step 1, this picture, picture number C, please put a star mark for picture number C. There's a 100 chance, 100% chance you'll receive this question at least 2 to 3 times in your UR. But whenever you see a female patient who comes with a growth on biopsy, they will tell you that we have found this sort of a picture in the biopsy. What is your diagnosis? The diagnosis is phyllodes tumor. As simple as that. Okay. Next one is gynecomastia. Is gynecomastia breast enlargement in males? Yes or no? The answer is yes, right? So gynecomastia is breast enlargement in males. Why? Because of increased amount of estrogen. If there's any male who has high amount of estrogen, that high amount of estrogen will convert the breast tissues into breast enlargement and that. Now, a very quick question. Males who are obese with a BMI above, let's say, more than 33 or high body fat percentages, do they have a lot of body fat? Yes or no? The answer is yes, right? And the fats of the body, do they contain a lot of aromatase enzyme? The answer is yes. All that aromatase enzyme, will it convert testosterone to estrogen? The answer is yes. This is why males who are very on the overweight side, on the higher side of the BMI, do they have problems with gynecomastia? Yes or no? The answer is yes. Another one is males who abuse steroids, for example, right? Males who abuse steroids, is there a possibility that exogenous steroid hormone from outside, for example, let's say there's a male who is abusing steroids for bodybuilding purposes or athletic purposes, right? Isn't there a possibility that out of 100% of the steroid that he is taking into his blood, only 60% is getting used up to build muscle and all the other things? Yes or no? The answer is yes, right? And then the rest of the 40% of the steroid, can it get converted to estrogen? Yes or no? The answer is yes, right? Because males also contain the enzyme aromatase. Males also contain the enzyme aromatase, and they convert all of these testosterone to estrogen. And that estrogen causes gynecomastia in male bodybuilders. Now, gynecomastia in male bodybuilders are not as evident as gynecomastia in your obese males. In male bodybuilders, usually the USMLE step 1 question is something like this, that there is a male who has a history of competing in professional bodybuilding or who is an athlete, now comes to you with a globular breast enlargement that is small and uniform. If there's a small uniform globular breast enlargement, can we consider that to be gynecomastia? Yes or no? Yes. The answer is okay. For example, this is gynecomastia, small globular enlargement of the breast. Okay. This is gynecomastia. This is not as evident as the BMI of if it's a very obese male, then the gynecomastia is very evident. But if it's a male bodybuilder, then the gynecomastias are not that evident because bodybuilders have a very low fat percentage, but they still have a globular breast enlargement. Have I made myself clear? Yes or no? Some other things, some other drugs that are very important for causing your globular breast enlargement are, number 1 is spironolactone. Then you have cimetidine. What is cimetidine? Cimetidine is an H1. It's an H2 blocker. Okay, then do we use cimetidine for prevention of gastric acid formation? The answer is yes, right? Then we also have finasteride. Finasteride is 5-alpha reductase inhibitors. Ketoconazoles, these are antifungals, right? So that's that. And we have some other diseases. For example, in liver cirrhosis, what happens? Why do we get high estrogen in liver cirrhosis? We get high estrogen in liver cirrhosis because the liver is involved for breaking down the hormone estrogen. It's involved for metabolizing the hormone estrogen. So if liver is compromised, do we have estrogen breaking down? Yes or no? The answer is no, right? So we have a lot of estrogen building up, and that causes different sorts of problems. In liver cirrhosis, not only do we get gynecomastia, do we also get Palmer erythema, spider angiomas? Yes or no? The answer is yes. Are they also due to estrogen or not? Yes or no? The answer is yes. Okay. That's that. And we obviously have Klinefelter syndrome, where estrogen is very high, and testicular tumors. Now, have I made myself clear with benign breast diseases? Okay. Okay, good. Now, let's talk about malignant breast diseases very quickly. Now, when I talk about malignant breast disease, what do we mean? When I say malignant breast disease, all the malignancies of the breast, do they arise from the necrophorus duct, major duct, or the terminal duct? That's the answer. They arise mostly from the terminal duct. Very good. Okay. Now, breast cancer in general is divided into two, meaning that there is carcinoma in situ and invasive carcinoma. Always remember this. There is carcinoma in situ and invasive carcinoma. What is carcinoma in situ? When I use the term in situ, right, this means that there is a malignant growth, but that malignant growth, has it invaded the basement membrane? Yes or no? Fast answers, please. The answer is no. So for carcinoma in situ, if I have to write the TNM stage, can it be T1 N0 M0? Yes or no? Or T0 N0 M0? The answer is yes. If it's invasive, then can we get, let's say, T2 N1 M0? Yes or no? Okay. What does N1 mean? Can anyone tell me what does N1 mean? Lymph node. Okay. A very quick question for someone. Very quickly, who can I ask the question to? I have a very high yield question. I just want to ask someone very quickly. Please write me in the chat box. I do not have a lot of time. Yes, Dr. VK, thank you so much.
Yes, doctor.
Okay, you have a tumor. Now, you are a resident physician, your attending is asking you to grade the tumor, grade it. Okay. If your attending physician is asking you to grade a tumor, are you going to grade a tumor based on TNM?
Yes.
Or are you going to grade the tumor based on the aggressiveness of the tumor? Which one?
TNM.
No. Okay.
Oh.
Grading of the tumor. Okay. I'm very glad that you tried to help me out. Okay. No problem that you gave a wrong answer. That's completely okay. When we use the word grade, we want to know if the tumor is a good tumor or a bad tumor. We want to see how aggressive this is. If we want to see how aggressive this is, do we have to see how anaplastic or dysplastic the tumor is? The answer is yes, meaning that how much deviation does the tumor have from the normal tissue, right? If the tumor is an adenocarcinoma, then it's a high-grade tumor. It's an aggressive tumor. If your attending physician asks you to stage a tumor, stage it, are you going to use TNM or aggressiveness, Dr. BK?
TNM.
Now you will use TNM. Okay. Now grading and staging is very, very important. What is grading? Grading means we want to know how aggressive the tumor is, how does the tumor look, how anaplastic the tumor is, what are the chances that, I mean, usually when we say high-grade tumor, exactly, what is the prognosis? Usually when we say high-grade tumor, we mean that the tumor is not a good tumor, it's a very anaplastic tumor, very high chance it'll spread very fast. So we need to act accordingly and emergently. When we say a high stage tumor, meaning that it's a very advanced stage tumor, but it could be a very low grade tumor that is advanced to a higher stage because the patient did not receive any treatment. Okay, so that's that. Oh, now since we have discussed on what is staging, what is grading, now let's talk about carcinoma in situ of the breast. So one more time, all the breast carcinomas, more or less, they will arise from the terminal duct, right? So let's talk about the terminal duct carcinoma. Treatment according to stage, treatment according to stage, yes, okay. Treatment is according to stage, but the dose of chemotherapy and radiotherapy, is it according to the grade, yes or no? The answer is yes, okay. Treatment is according to stage. That is, do we need chemotherapy, surgery, or do we need chemotherapy, surgery altogether? That's according to stage. But how much chemotherapy should we use? How much surgery should be performed? Should we take off the entire organ or just a little bit of the organ? That depends on the grading of the tumor, okay? So high-grade tumor, do we give more aggressive treatments? Yes or no? The answer is yes, okay. Are we clear, guys? Yes or no? Yes, okay. So let's talk about carcinoma in situ of the breast. We have two types of carcinoma in situ. First and foremost, if the carcinoma in situ arises from the duct line, right? For example, let's say that this is the breast tissue, right? This is the lactiferous duct, major duct, and then you have the terminal duct, okay? If the carcinoma arises from the duct lining, we call this ductal carcinoma in situ. If the carcinoma arises from the lobule, we call this lobular carcinoma in situ, right? So what is ductal carcinoma in situ? Ductal carcinoma in situ is basically, it's basically a carcinoma which affects the duct lining. And in ductal carcinoma in situ, we see calcifications. That is very high yield. That is calcification. Now, how do you know that this is ductal carcinoma in situ, or if anything like that? Okay. Now, let's say that you are a gynecologist and a breast physician. Okay. You have a patient who comes to you, and the patient has growth in the terminal duct. Are you going to be concerned or not concerned? Fast answers, please. The answer is, if there's a patient who comes to you with a growth in the terminal duct, you are going to be concerned, because growth in the terminal ducts are not good. Growth in the terminal ducts are associated with carcinomas. And majority, if you see that the growth in the terminal duct is arising from the duct lining, and it's calcified, right? Then can you assume that this is ductal carcinoma? Yes or no? The answer is yes, right? So that's that. Next one is lobular carcinoma in situ. Lobular carcinoma in situ is a lesion that is arising from the lobule. The difference is that lobular carcinoma does not have any calcification. And, okay, and obviously they are appearing over here from the lobules. There's another pathology with why do we get lobular carcinoma? The pathology is that cells of the lobules, they are attached with each other, right, via intracellular protein structures. And these intercellular protein structures are very important because there is a mutation with E-cadherin, right? Now, the mutation is that this mutation of E-cadherin, if we have decreased E-cadherin, let's say that this is a loss of function mutation, we have a decreased E-cadherin, what happens is that the intracellular protein structures, they break down. When the intracellular protein structures break down, is it much more easier for the malignant cells to move and metastasize locally? Yes or no? The answer is yes, right? So lobular carcinoma is a carcinoma that is associated with decreased E-cadherin expression, right? So that's that. So that's all about ductal carcinoma and your lobular carcinoma being in situ, right? There's another non-invasive in situ carcinoma. This type of carcinoma is known as the Paget's disease of the breast. This is known as Paget's disease. What is Paget's disease? Paget's disease of the breast is that they do not have a proper mass. Okay? We do not see any mass over here. What we do see is diffuse inflammation of the breast. The breast is diffusely enlarged. The breast is diffusely inflamed, right? And there is extreme amount of pain and eczema. That is, patients, they will have diffuse inflammation and pruritus, right? They will have diffuse inflammation, pruritus, and along with this, we will see all sorts of negative signs. What are some negative signs? We will see nipple retraction, nipple inversion, and lymph node enlargement. Okay, and the breast will appear inflamed, enlarged, eczematous, and pruritic. These type of carcinomas are known as breast carcinoma. Do we have to do a biopsy? Yes or no? The answer is yes. In Paget's disease, if we ever see a patient who comes to you, if we ever see a patient who comes to us with, let's say, a year-long inflammation of one-sided breast, of unilateral breast, right? Along with this, the patient has severe pruritus, and you see small areas of necrosis. Are you going to take a small amount of tissue to do a biopsy? Yes or no? The answer is yes, right? What are you going to see on the biopsy? What you're going to see on the biopsy is, you will see intraepithelial adenocarcinoma, meaning very small glandular carcinomas in the lactiferous ducts. Have I made myself clear? Yes or no? Okay. Have I made myself clear? Okay. So if I had to say one carcinoma that can arise from the lactiferous duct, what would be the name of that carcinoma? Paget's disease. Very good. Okay, so that's that. So that's all about in situ carcinomas. Now let's talk about invasive carcinomas. So once again, if we have to talk about invasive carcinomas, okay, then what do we have? Again, lactiferous duct, major duct, and terminal duct, right? Now, if you have to talk about invasive carcinomas, now, once again, if there's a carcinoma that is arising from the duct lining and it is invading the duct lining, can we say this is ductal carcinoma? Yes or no? The answer is yes. Another one is if there's a carcinoma arising from the lobule of the terminal duct and they're invading, they are lobular carcinoma. Okay, so that's it. Now, what is ductal carcinoma? Ductal carcinoma is usually when they are invasive and they invade, right? They usually present with a rock hard mass, a very rock hard mass, irregular. It is very irregular. They are not mobile. Under ultrasonogram or mammography, you will see that they are not capsulated. Okay. So if you see something like this, rock hard, irregular, not mobile, not capsulated, and they're arising from the duct line, what is your diagnosis? The diagnosis is ductal carcinoma. As simple as that. If you see another sort of a cell which are multiple in number, same irregularity, non-mobile, and non-mobile, and you also have bilateral lesions, then that is lobular carcinoma, and specifically they will arise from the lobule of the terminal duct. Have I made myself clear? Yes or no? Okay. Okay, good. So that's basically all about our discussion. We have two other carcinomas, that is medullary carcinoma and inflammatory carcinoma. That's not very, very high yield. So that's that. Now let's jump into the text of the breast cancer. So breast cancers, they're very common in lobulars bilateral. Yes, they could be bilateral. They could be bilateral. Okay. Are we ready to start the text? Yes or no? Fast answers, please. Okay. Breast cancer. So breast cancer, this is commonly present in postmenopausal women because breast cancer, is it an estrogenic tumor? Yes or no? Fast answers, please. The answer is yes. Breast cancer is an estrogenic tumor. Females who have high amount of estrogen, they are at risk of developing breast cancers. So they're often present as a palpable hard mass and in the upper outer quadrant. Oh, this is one thing I forgot to mention. Always remember this. If this is the breast, right? The breast have 4 quadrants. Okay, wait, just give me 1 second. 1 second. Okay, let's say that this is the female thoracic cavity, right? In this female thoracic cavity, you have the left breast, you have the right breast, right? And in the left breast and the right breast, in between, this is the midline. The left breast and the right breast, you can divide them in 4 quadrants like this. Okay, these are the upper quadrants, these are the lower quadrants. Breast cancer in females is always very, very high yield, that they always develop in the upper outer quadrant. Upper outer quadrant, that is upper and lateral. Okay? And the majority of the breast pathologies and the breast cancers that develop in the upper outer quadrant, they will almost always affect the axillary lymph nodes. Okay, they will almost always affect the axillary lymph nodes. Another very high yield clinical question: if there is a patient with advanced breast carcinoma, isn't there a possibility that they can get lymphatic swelling of one arm? Yes or no? The answer is yes, right? Because the lymphatic drainage of the arm can get hampered if the breast growth is invading the lymph drainage, right? So we can get unilateral enlargement due to lymphatic fluid accumulation. So that's it. So they're most common in the upper outer quadrant. Please underline this. Now, there's another thing that I want you guys to deeply understand. This next line is a question. Invasive cancer can become fixed to the pectoral muscles, deep fascia, Cooper ligaments, or overlying skin. When the invasive cancer, right? When the invasive cancer is invading into the overlying skin and the Cooper's ligament, we get nipple retraction and skin dimpling. Please underline this. Nipple retraction is something that we get when the cancer invades the overlying skin. Okay. Can anyone tell me when do we get putty orange? Fast answers, please. Do we get putty orange when we get lymphatic invasion? I mean, invasions of the small lymph nodes of the breast? Yes or no? The answer is yes. Okay. When do we get nipple retraction? When we have the invasion of the Cooper's ligament. Very, very high yield. Cooper ligament and skin gives you nipple retraction. Putty orange is something else. Do not confuse putty orange with nipple retraction. Okay. It usually arises from the terminal duct lobular unit, very high yield. And why do we get this? Because there are females who are at risk of being a victim of a mutation, right? What is the mutation? The mutation is in a receptor of, the receptor is an estrogen progesterone receptor, right? Now, the thing is, if there is a mutation, right, hear me out. If there is a mutation that is resulting in gain of function of the estrogen and the progesterone receptor, will there be a lot of activity of the estrogen and the progesterone receptor? Yes or no? In a gain of function mutation, gain of function. The answer is yes. If there is a lot of activity of the estrogen and the progesterone receptors, what will happen to the estrogen and progesterone? For example, let's say in the absence of estrogen and progesterone, the receptors of estrogen and progesterone in the breast are stimulating the breast growth. Isn't there a possibility that that can result into excessive amplification or abnormal proliferation of the breast tissues? Yes or no? The answer is yes. Okay. So there is a mutation called gain of function mutation, in which there is mutation of the estrogen and the progesterone receptors. And the estrogen and progesterone receptors, when they mutate, they stimulate the cells without the presence of estrogen and progesterone. That results in amplification and overexpression of these receptors, and patients are more at risk of developing a breast cancer. So if there is, for example, let's say that there's another thing. If breast cancer is positive for estrogen receptor, right? If a breast cancer is positive for estrogen receptor, if a breast cancer is positive for progesterone receptor, then if we simply stop giving estrogen or progesterone, or we give some sort of an monoclonal antibody that works against estrogen and progesterone, isn't it easier to treat the breast cancer? Yes or no? The answer is yes. For example, let's say that there's a breast cancer where estrogen receptor is positive and progesterone receptor is positive. There's another breast cancer where estrogen receptor is negative, progesterone receptor is negative. Progesterone receptor is negative. Now, for this sort of a cancer, if we simply block the estrogen receptor and the progesterone receptor, can we expect the breast tumor to decrease in size? Yes or no? The answer is yes. But how about tumors that are not positive for estrogen receptors and progesterone receptors? Will it be very difficult for us to treat these tumors? Yes or no? The answer is yes. Because for these tumors, do we need chemotherapy, radiotherapy, surgery? Yes or no? The answer is yes. Okay. So ER positive, ER and PR positive cancers, they're good cancers or bad cancers? Fast answers, please. Fast answers for breast cancers. Bad, but easy to treat. Okay, good. So triple negative, ER negative, PR negative, they are very aggressive. This is why I was explaining this. What are some risk factors for breast cancers? Risk factors for breast cancers are one of the highest risks for history of breast cancers in the family. So family history of breast cancer, very, very high yield, okay? And okay, look, there's one thing which I want to bring to your attention. Do you see how first aid has written white patients and black patients? Yes or no? Do you see this? White patients, black patients, okay. As a physician, should you use color to differentiate your patients? Yes or no? Fast answers, please. The answer is no. But should you use proper ethnical terms? Do you know what ethnical terms are? Okay, ethnical terms. You know, like a lot of international medical graduates, they read this sort of thing, and then when they go to residencies, they refer to patients as, oh, there's a black patient in room number 10, or oh, there's a white patient in room number 12, or there's a blue patient in room number 5. So do not use color to address your patients. What you should use is an ethnical term. Ethnically, for white patient, do we say that they're Caucasians? Yes or no? Caucasian. The answer is yes. For black patients, do we use African Americans? Right? The answer is yes. Okay. Better to use these terms because they are more respectful. So Caucasians and African Americans, they are more at risk of triple negative breast cancer. That is that. Another very high yield risk factors is BRCA1 and BRCA2. Right? BRCA1 and BRCA2. These are mutations that can result in growth of the breast cancer. And then females who are exposed to high amount of estrogen, obese females, or anything that increases their estrogenic risk will cause breast cancer. I mean, will put them at risk of breast cancer. So that's that. In males, we can also get breast cancer due to Klinefelter syndrome and BRCA2, that is that. And axillary lymph node metastasis is most important prognosis in the early stage of the disease, okay? For example, when we find out that there's a patient who has breast cancer, do we do a sentinel lymph node mapping? Yes or no? The answer is yes. What do we mean by sentinel lymph node mapping? Sentinel lymph node mapping means we map, for example, let's say that we find the tumor in this region, right? We find the tumor in this region, and then we try to see if there's any lymph node that is affected in the breast or not. So we try to see the lymphatic drainage of this portion of the breast, and we try to see if they have affected the axillary lymph node or not. If we find out that the axillary lymph node is affected, do we immediately go for surgery with removal of the lesion and lymph node dissection? Yes or no? The answer is yes. Okay, that's it. Okay, now, Dr. Sana, what question do you have? Fast question, please. We do not have a lot of time.
Dr. Hedri, regarding ER/PR, I have a query. Those patients who have ER/PR positive, we said that their cancer is bad but easy to treat. I mean, what does this statement mean? Is it are they more aggressive, or uh, and those which are triple
Okay.
negative, they
Cancer
are
aggressive.
difficult?
Okay, no, my apologies. Please finish your question first.
And those which are triple negative, like ER/PR and HER2, they are more aggressive and difficult to treat.
Okay. So first and foremost, I'm not talking about aggressiveness. Aggressiveness is once again defined by how a tumor appears, right? For example, ER positive, PR positive, HER2 positive tumors can also be really aggressive because if they have a bad appearance or if they're very dysplastic or anaplastic. But what I'm talking about is treatment. I'm talking about the fact if it is good or not based on our availability for treatment. For example, if a tumor is ER positive, PR positive, HER2 positive, can we start our treatment with anti-estrogen, anti-progesterone? Yes or no, Dr. Sana? The answer is yes, right?
Yes.
And then after that, if that doesn't work, then we can go for chemotherapy, radiotherapy, surgery, immunotherapy, or whatever. But in a patient who has ER negative, PR negative, and HER2 negative, can we start the treatment with hormone therapy? The answer is no, right? So we are already losing one module of treatment.
Exactly.
I mean, when it comes to cancer, the more modules of treatment there are available, the better it is for the patient because that gives them more chances and options. But a tumor that is already ER, PR negative, that we are already losing our chance of treating the patient. So that's why I'm saying that it's worse to have an ER negative, PR negative. Okay.
Got it. Thank you.
You're welcome. Thank you so much. Okay. Let's talk about these things. I have already talked about this, ductal carcinoma in situ, right? This is, as you can see, this is over here. Now, I came back to the first stage because I want to talk about the biopsy findings. Now, in the biopsy, you can see that this is the lobule, and look, this is the duct, and this tumor is arising from the duct lining. Okay, whenever you see something like this is ductal carcinoma in situ. It arises from the ductal atypia. We see microcalcifications. That's very important. Hematocarcinoma is a subtype of DCIS, and cells have a high-grade nuclei with extensive central necrosis and dystrophic calcification. So something like this. You do not have to remember so many things. Just remember if there is a tumor that is arising from the duct lining that is calcified. What sort of a tumor is this? This is ductal carcinoma. Next one is Paget's disease. This is Paget's disease. This is the disease that is Paget's disease. You see inflammation, pruritus, eczematous, necrosis, and all of these things over here. And they arise from the terminal duct or the lactiferous duct? The answer is they arise from the lactiferous duct. And since the lactiferous ducts are the ducts that are closest to the opening of the nipple, right? They're over here. That's why this tumor extends and it affects the skin area, as simple as that. Okay, so we see eczematous patches over the nipples and the skin. If we do a biopsy, we can get Paget cells, as simple as that. Lobular carcinoma in situ is a carcinoma that is arising from the lobules. There's no mass, and it's an incidental biopsy finding. That's all. Invasive ductal carcinoma is rock hard. Duct-like cells in a desmoplastic stoma, not important. Invasive lobular carcinoma are the same thing, except they have invaded, right? And they are bilateral. They could be bilateral with multiple lesions. Okay, now let's talk about medullary carcinoma. These are large anaplastic cells which grows associated with lymphocytes and plasma cells. They're well-circumcised tumors. They can mimic fibroadenoma. Now, another very high yield thing, when a patient comes to us with fibroadenoma or fibrocystic changes, do we tell the patient it's benign, yes or no? The answer is yes, right? We tell the patient it's benign, but do we also do a biopsy to confirm if it's benign or not? The answer is yes, because if you do not do a biopsy, are you 100% sure it's a benign cancer? The answer is no, right? So later, let's say that you told the patient that it's a fibroadenoma, and later you find out that it's not fibroadenoma, it's a medullary carcinoma. Did you just destroy the patient's life and also ruin your credibility as a physician? Yes or no? The answer is yes. So one more thing, as a physician, especially in this country, especially as an international medical graduate and an immigrant, is it important for you to be safe 100%? Yes or no? The answer is yes, right? Because if you're not safe, then what do you get? Do you get lawsuits? Yes or no? Do you get lawsuits or not? The answer is yes. Okay, good. Next one, inflammatory. Inflammatory carcinoma is this sort of a carcinoma where you see dermal lymphatic space invasion, warm, swollen, erythematous breast with beauty orange. As you can see that there is red congestion and enlarged, and there is a globular growth of the breast. But over here, do you see any mass? Yes or no? The answer is no. There is no mass in inflammatory carcinoma. Okay. So if there's no mass in inflammatory carcinoma, how do you diagnose this? You do a biopsy, and in your biopsy, you find anaplastic cells. And inflammatory carcinoma is one of the worst carcinomas to have because it has a very poor prognosis. As simple as that. Okay. Did we understand breast cancers and breast diseases? Yes or no? Yes. Everyone, are we clear about breast cancers, breast diseases? Can I give you guys 2 minutes to read the breast disease? I'll ask you questions and then I'll move to penile pathologies. Okay. Okay, is everyone done? Yes or no? You should not need a lot of time to review the breast diseases. Is everyone done? Okay. If you have a female who comes to you with breast lesion that is small, uniform, mobile, premenstrual breast pain is there, what is your diagnosis? Fast answers, please. Fibradenoma. If you have a female who comes to you with multiple nodular breast lesions with premenstrual breast pain, what is your diagnosis? Not mobile. Okay. Out of fibrocystic changes, we have two types: sclerosing adenosis and epithelial hyperplasia. Which one is more high yield? I mean, which one is more related to cancer? If you have a patient who comes to you with a lesion, you do a biopsy, and the lesion is arising from the stroma. They have leaf-like wobulation. What is your diagnosis? Phyllodes tumor. If you have a patient who comes to you with a lesion in the duct of the terminal duct of the breast, it's arising from the epithelial lining, and it has not invaded. It consists of microcalcification. What is your diagnosis? If you have another patient who has a breast lesion that is inflammatory, eczematous, pruritic, nipple necrosis is there, what is your diagnosis? Paget's disease. If you see another patient who has uniform enlargement of the breast with congestion, there's no palpable mass, but there's purity orange, and the breast looks inflamed. It's an inflammatory carcinoma. Okay. ER negative, PR negative, HER2 negative breast cancers are better, or ER positive, PR positive, HER2 positive breast cancers are better? Okay. So whenever we diagnose a patient with breast cancer, do we have to find out if the cancer is positive for these things? Yes or no? The answer is. Okay. Let's begin with penile pathologies. Is everyone ready? Yes or no? Penile pathologies are very easy to understand. And I'm going to use the first aid book to read and let you know how the questions are going to come. The questions are going to be structured from this portion over here. The answers are usually, what is the name of the disease? Okay, so that's it. So I'll talk about all of these diseases over here very quickly. Let's talk about the first disease. The first disease is known as Peyronie's disease. Peyronie's disease. Peyronie's disease, as you can see, is that this is an inversion of the penis, where you have an abnormal curvature of the penis. Why? Because over here, there's some sort of a fibrous deposition. There's a fibrous plaque, especially in the tunica albuginea, right? Tunica albuginea is one of the coverings. So you have a fibrous plaque over there. So whenever we have the growth of the penis happens around the fibrous plaque. So if there was no fibrous plaque, then the growth should have been uniform and enlarged this way. But since there is a fibrous plaque, there is an abnormal curvature towards the posterior region. This causes severe pain, anxiety, erectile dysfunction, infertility, right? And this is very, very treatable. We treat this with surgery, and sometimes if the patients do not want to go for surgical procedures, we can give substances that will break down the fibrous plaque. For example, we can give collagenase. And when we give collagenase injections, what they do is we give intrapenile collagenase injections. These injections, they break down the fibrous plaque, and patients, they can have cured of their curvature, as simple as that. This is very important for a differential diagnosis for another sort of a clinical picture, where you will get patients who come to you with history of sexual activity now comes with an inversion of the penis, or lateral growth, or the penis appears that the shaft is displaced laterally with excessive pain and blood at the meatus. What is your diagnosis? The diagnosis is penile fracture. Okay, penile fracture. Have I made myself clear? Yes or no? Very high yield for step 1 and step 2 CK. Did we understand Peyronie's disease and penile fracture? Yes or no? Yes. Okay, good. Let's talk about the next one, ischemic priapism. What is ischemic priapism? What do we mean by priapism? Priapism means painful erection, right? If there is a male who has had sustained erection for more than 4 hours, right? What that does is that causes severe lack of blood supply to the portions of the penis. And there's another thing. Patients get priapism because of what? Arterial compromise or venous compromise? Fast answers, please. Patients get priapism due to arterial compromise or venous compromise? The answer is venous compromise, meaning that the arteries are bringing in the blood, but the veins are compromised, so they cannot take the blood away. As a result, the organ stays congested. So they block the venous drainage. We usually see this in multiple things. We see this in a very high yield psychiatric antipsychotic medication that is known as trazodone. We do not use this right now because it's known to cause priapism. And this is very, very important. You will be asked about this in your step 1 exam. Trazodone, they cause ischemic priapism. So does sickle cell anemia. And sickle cell anemia, can we get sickling of the RBCs in the veins? Yes or no? The answer is yes. If there's sickling of RBCs in the veins, can the blood drain properly? The answer is no, right? So that's it. We also see this in a lot of different types of medications. For example, sildenafil or Viagra, and another sort of medication that we abuse, that is cocaine. Okay, so that's it. So we treat this immediately. This should be treated because if we do not treat a priapism and there is onset of ischemia, isn't there a possibility that there could be necrosis of the penis? Yes or no? The answer is right. The answer is yes. So we immediately drain the blood from the vein so that the blood can go out. So we do corporal aspiration from the deep dorsal and especially the deep dorsal vein. Do you guys remember the cross section of the penis? Yes or no? How we have a deep dorsal vein over here. We have the true corpus and we have the urethra over here. Yes or no? So we inject in the deep dorsal vein and we try to take the fluid out. Well, when we take the fluid out, we try to make sure that the blood that was being brought in by the arteries, now they can leave through the vein. And also we do intracavernosal phenylephrine. Why do we give intracavernosal phenylephrine? Is this a vasoconstrictor? Yes or no? The answer is yes. Can they cause vasoconstriction of the arteries? Transient vasoconstriction of the artery? The answer is yes. Okay, so that's that. And if corporal aspiration or intracavernosal phenylephrine, if that doesn't work, then we can always go for surgical decompression. That's simple. Okay. That's all about ischemic priapism. Now let's talk about squamous cell carcinoma. Okay. First and foremost, what is balanitis? What is balanopostitis? Okay. Balanitis, inflammation of the glans penis, is called balanitis. Balanopostitis is inflammation of the glans penis and the shaft. Okay. These are two terms you need to get associated with. Now, balanitis is usually seen. This is very common in the US, but more common in Asia, Africa, South America. And this is squamous cell carcinoma, which I'm talking about. Okay? Now, from the top of your head, why do you think that that males get squamous cell carcinoma? Fast answers, please. Why do males get squamous cell carcinoma of the penis? Can anyone tell me very quickly? HPV, yes, very good. HPV, very, very high yield. It's associated with HPV and uncircumcised males. Okay, this is very high yield. Whenever a male is uncircumcised, right, that is, they do not get rid of the extra skin. Isn't there a possibility that there could be accumulation of unhealthy fluid around the uncircumcised skin? Yes or no? The answer is yes. Does anyone know what we call, what is the name of that fluid that accumulates, that toxic fluid that accumulates around the uncircumcised skin? No. The name of that fluid is called smegma. Okay. And that smegma, for example, how many of us have seen a circumcision in a surgical procedure? Have you guys ever conducted a circumcision? Yes. Okay. Dr. Ethanol once. Dr. Tasneem, yes. Can you answer a very quick question, Dr. Tasneem? Whenever surgical professors will perform a circumcision, do they retract the skin and wash the glands with an iodine solution? Yes or no? Yes. The answer is yes. Okay. Why do they wash that area with iodine solution? Because they are getting rid of the smegma. As simple as that. So let me tell you why you need to wash the glans penis after you retract the skin. Because when you perform the surgery, right, isn't there a possibility that if you do not get rid of this smegma fluid, this can get invaded into the patient's blood vessel? The answer is yes. Okay. So very, very important. Very, very important that you get rid of this fluid. That's that. Now, so uncircumcised males and HPVs, they're very high yield. And how do they get the lesion? First, there's a white lesion. That white lesion is known as leukoplaque. And then that white lesion becomes red because of the invasion of the surrounding blood vessels, and there is bleeding into the surface, and that becomes erythroplaque. So leukoplakia and erythroplakia. These are precancerous lesions, precancerous lesion. Okay. Have I made myself clear? Yes or no? There's another one called bionoid papillosis. It's not very high yield. It's carcinoma in situ. And they have reddish papules, but there's no question in your step 1 exam for this. Have I made myself clear with squamous cell carcinoma of the penis? Yes or no? Okay. Why is the response rate a little bit low today? Are you guys tired? Are you guys not feeling it? Are you guys tired? Yes or no? Kirath. Erythroplasia of Kirath is erythroplakia. Erythroplasia of Kirath is erythroplakia, the same thing. That is, this is a carcinoma in situ precancerous condition where you have invasion of the blood vessels. That's why I've said erythroplakia. It's the same thing. Oh, are we ready to begin cryptorchidism? Yes or no? Let's begin cryptorchidism. Let's begin cryptorchidism. What is cryptorchidism? First and foremost, the testes, do they develop in the abdomen? Yes or no? The answer is yes. Then, with the help of a fibrous tissue, can anyone tell me the name of the fibrous tissue? What is the name of the fibrous tissue? The name of the fibrous tissue is known as gubernaculum testis. Very good. Gubernaculum testis. Very quickly, the female derivative of gubernaculum testis is, past answers, which ligament is the derivative of gubernaculum testis? And which ligament? Ovarian ligament and which ligament? Round ligament. Very good. Okay. That's it. So what happens is that we have intra-abdominal development of the testis, and then after that, with the help of the gubernaculum testis, one portion attaches to the scrotum, another portion attaches to the testis in the inguinal canal. And then this gubernaculum, this pulls the testis down like this, and the testis comes from the inguinal canal and comes to its normal anatomical position in the scrotum, right? So if we have a patient who has decreased activity of the gubernaculum testis, can they have descent of failure of one or both testes? Yes or no? The answer is yes. And the testes, are they created to withstand the extremes of temperature in the abdomen? Yes or no? The answer is no, right? So when the testes, they're not removed, they stay in the abdomen. If they stay in the abdomen, can we get testicular compromise? The answer is yes. Will the testicles, will they produce sperm? The answer is no. Can the patients get infertile? The answer is yes. With high temperature that they're exposed to in the abdomen, can we have metaplasia, dysplasia, anaplasia? Yes or no? The answer is yes. Okay. So they can have normal testosterone level, but there's an increased risk of germ cell tumor. So prematurity with increased risk of cryptorchidism. Oh, another high yield question. If there's a newborn baby with cryptorchidism, do you do surgical orchidectomy, or do you wait for the testes to come down? Which one? You wait. Very good. How long do you wait? Do you wait for the first year, yes or no, for the testes to come down? The answer is okay. In most cases, they resolve spontaneously. Otherwise, orchopexy is performed before 2 years of age. So you basically wait from 0 to 1 year, and then after that, if it doesn't come down, then you can do orchopexy Before 2 years of age. Okay, so that's it. And prematurity is with increased risk of cryptorchidism. And if we have cryptorchidism, for example, if the Sertoli cells are damaged, then will there be inhibin? Yes or no? The answer is no. So FSH and LH is going to be high. Are we clear? Yes or no? Okay. Next one, very high yield free exam, testicular torsion. Testicular torsion is basically when the testis, they get torsioned around the spermatic cord. So the rotation of the testis around the spermatic cord. This is very, very important, and this is very, very common, right? What happens is that there will be questions where you will have patients who come to you in a state of emergency. Male patients will come to you, especially young patients, teenage patients or young adults. They will come to you with extreme pain in the lower abdomen and in the testis, right? The pain is so extreme that patients, they will not be able to move. They will have severe pain, vomiting, right? And another thing is that they will have absence of their premenstrual reflex. This is a physical examination that's very high yield. Another one is the side where you have the testicular torsion, that is, let's say the left side testis, since it's torsed, let's say this is the right testis, the left testis, if it's torsion, it will appear as if it's high riding, that is, it's increased in height, that is, it's placed at a higher anatomical location. So that's it. So that's basically what it is. It's acute severe high ride, acute severe pain in the testis, and we also get negative French sign. Does anyone know what French sign is? What is French sign? Can anyone tell me? What is French sign? Okay. French sign is, okay, French sign is, for example, what we do is that, let's say that this is the scrotum, right? Over here you have one testis and you have another testis. French sign is that the physicians, they use their hands to elevate one-sided testis. Let's say this is the right side, this is the left side. The patients have a left-sided testicular pain. If we do a French sign and we try to elevate the testis, right? If it resolves the pain, then French sign is positive. Okay. If it does not resolve the pain, then French sign is negative. Have I made myself clear? Yes or no? Fast answers, please. Okay. Now, can anyone tell me in which type of a testicular condition do we get positive French sign? The answer is epididymitis. Are we clear? Yes or no? Okay. Okay, good. So that's it. And absent of cremasteric reflex. What is absent of cremasteric reflex? What is the cremasteric reflex? Do we try to see if we have contractions of the abdomen, the abdominal muscles when we stroke the cremasteric nerve? Yes or no? The answer is yes. Let me show you cremasteric reflex. So what happens is, let's say this is your patient. So this is the test. So this is the cremasteric nerve, right? You stroke the nerve, and then what happens? If you stroke the nerve, if the reflex is positive, what happens is that we get elevation of the testis and we get contractions of the lower abdominal muscle. This is a positive cremasteric reflex sign, right? If we have absence of the cremasteric sign, then doesn't that mean that the nerve like over there is compromised? Yes or no? The answer is yes. What is the name of the nerve that gets compromised in the cremasteric reflex? I said cremasteric nerve. There's no such thing called cremasteric nerve. That's my mistake. The name of the nerve is genital. Dr. Ethar has already mentioned the name of the nerve is genitofemoral nerve. Have I made myself clear? Yes or no? Okay. Okay, good. So very quickly, if there's a male who comes to you with abnormal curvature of the shaft and you see a fibrous plaque, what is your diagnosis? Fast answers, please. What is your diagnosis? Peyronie's disease. If there's a male patient who comes to you with exposure with let's say sildenafil or trazodone, now comes to you with sustained erectile contractions, what is your diagnosis? Priapism. Very good. If there's a male who comes to you with an irregular lesion on the glans penis with bleeding, what is your diagnosis? Carcinoma of the penis. If you see absence of testis in the scrotum on one side, what is your diagnosis? Cryptorchidism. If a male patient comes to you with severe pain, high riding testis, and absence of the cremasteric reflex, what is your diagnosis? The diagnosis is testicular torsion. As simple as that. If testis is not viable, let's say that we try to, for example, when there's a testicular torsion, the patients, they need to have the surgical correction within 6 hours, because after 6 hours there will be testicular necrosis. If we cannot do if we cannot fix the torsion, then we can do surgery. Now the thing is, and there's another question, when you do one-sided orchiopexy, not orchiectomy, when you do one-sided orchiopexy, do you also do another sided orchiopexy? Yes or no? The answer is yes. Even if the another side is not, even if the another side is not affected with the torsion, right? Even if another side is not affected with the torsion, we do orchiopexy of another side because there's a possibility, since one side has undergone torsion and another side can undergo torsion too. So that's it. And if the patient comes at a later time, let's say after 12 hours, and we see that the testis has been necrosed, it's not viable, and we can get rid of the testis. It's called orchiectomy. Okay, so that's it. Next one is a varicocele. Is everyone ready? Yes or no? Is everyone ready? Varicocele. What is a varicocele? Do we said left? Do we get left-sided varicocele more or right-sided varicocele more? Fast answers, please. Left-sided. Why? Can anyone tell me why we get left-sided varicocele that are more common? Because the left gonadal vein drains into the left vein in a right angle. Yes or no? So isn't there a chance that we can have a higher increase of turbulent blood flow? Yes or no? The answer is yes. So dilated veins in the pampiniform plexus, which appears as a bag of worms. Bag of worms. This is the sort of description. Bag of worms appearance in the testis. Due to increased venous pressure, most common cause of scrotal enlargement, and left side because of increased resistance to flow, as simple as that. This swelling, if you try to decrease the swelling by manually, will it go down? Yes or no? First answer, please. The answer is no. Very good. Will the swelling increase with Valsalva maneuver? Yes or no? The answer is yes. Now, if you do not treat the patient, what is the number one complication of varicocele? Infertility. Number one complication of varicocele is infertility. So that's a bag of worm palpation. On ultrasound, it will not transilluminate. Can you tell me one testicular lesion that will transilluminate? One testicular lesion that will transilluminate is a hydrocele. Very good. Treatment is by surgical correction and ligation of the embolization with pain or infertility. Okay, so we do surgery, as simple as that, surgical ligation of the veins, as simple as that. Is everyone clear? Yes or no? No. Is everyone clear about what we have learned today? Breast pathologies and penile pathologies. Okay, so who wants to take a break? With which drug? Embolization with which drug? What do we mean? What do you mean by which drug? Embolization. What is embolization? What is embolization? Before we go, what is embolization? Can you explain the procedures? I will explain the procedure, but does anyone know what embolization is? embolization is basically, we have a procedure that what we do is, this is a minimally invasive sort of a procedure. What that does is that this allows, for example, if there is a blockage of a blood vessel, right? If a blood vessel is blocked, let's say this could be a vein in majority of the conditions, we remove the block and then we make sure that the proper arterial supply and the venous drainage is happening or not. Okay. Now the thing is, we can do embolizations to stop bleeding. We can also do embolizations to make sure that there is preservation of normal blood flow to an organ. Do we have any drug that we give for embolization? The answer is usually we do not go for any drug. We go for surgical methods, where in majority of the cases we can use a catheter if needed to break down an emboli, if there is one, to make sure that the blood flow is sustained. That's number one. Number two is we can use drugs. It's not like we cannot use drugs. We can use drugs. For example, we can use thrombolytics that breaks down the thrombus. So if the embolization, that is breaking down of the emboli and restoration of the blood flow, if it doesn't happen with the catheter, then we can give antithrombotics or thrombolytics to break down the thrombus and restore the blood flow. Have I made myself clear? Yes or no? Yes. Okay. Now, can we take that break? Do you guys have any more questions? No questions. Okay, good. So let's take a break for 15 minutes. It's 12:25. Let's take a break to 12:40. Thank you so much. I'll see you guys in 15 minutes. Okay, is everyone back from their break? Can you guys hear my voice? Yes or no? Is everyone back from their break? Can you guys hear my voice? No. Okay, just give me 1 second. Okay, so far we have finished penile pathologies. Now we will begin with testicular tumors and testicular carcinomas. And then after that, we will move forward to testicular inflammations. Okay. Give me 1 quick second. Okay. Okay, so we are going to start from extragonadal germ cell tumors. So one more time, I apologize for asking this so many times. Is everyone ready? Yes or no? Okay. Let's begin. Extragonadal germ cell tumors. Always remember this. Extragonadal germ cell tumors will always arise in the midline. Okay. Germ cells. Germ cells means this is the developing embryo, right? Germ cells are cells that line the midline. So whenever they say germ cell tumors, always remember that the tumors will arise from the midline of the human, right? So in adults, most commonly it's in the retroperitoneum. It could also be in the mediastinum, pineal gland, suprasellar regions, not important. What is important is if there is a young child who comes with a sacrococcygeal tumor and tumor in the ovaries, a female child, what is your diagnosis? Left hand, please. Yolk sac tumor. There you go. Okay. So sacrococcygeal tumors in young children are very, very important. So do not forget that. Now let's talk about benign lesions of the scrotum, and then we'll talk about malignant lesions. When we say benign scrotal lesions, the number one lesion I want you guys to understand is hydrocele. Hydrocele is accumulation of the fluid due to incomplete obliteration of the processus vaginalis. Incomplete obliteration of processus vaginalis. What is processus vaginalis? Processus vaginalis is a fold of peritoneum that lines the scrotum, and over time they should obliterate. If this fold of peritoneum, that is processus vaginalis, if it does not obliterate, can we have accumulation of the peritoneal fluid in the scrotal sac? Yes or no? The answer is yes. Okay. So these patients, they will come to you with a scrotal swelling. Transillumination will be positive. They will be non-reducible, or they could also be reducible sometimes, depending if the swelling goes up or goes down. In majority of the cases, they are non-reducible. They are present from a very young age, right? And this should be addressed in a surgical intervention method. So that's that. Then we have acquired hydrocele. Acquired hydrocele is, for example, for any reason, if there's accumulation of fluid in the scrotum without the presence of processus vaginalis. This could be due to trauma. This could be due to a tumor, right? This could be due to anything that results in accumulation, and especially the accumulation is bloody accumulation. So we get hematocele, very important. Okay, hematocele. What is spermatocele? Spermatocele is cystic dilatation due to dilated epididymal duct or retrotestis. Dilated epididymal duct or retrotestis. This is spermatocele. As you can see, that this is the dilated portion. This is hydrocele. And this, as you can see, can you guys see this? Can you guys see this blue line? This blue line, yes or no? This blue line is the connection of the processus vaginalis to the abdominal peritoneum. Okay, so that's how the peritoneal fluid, they come down. Have I made myself clear? Yes or no? Okay. This is a very good diagram of the testicular lesions. Look at this. This is the normal testis. This is accumulation of fluid, spermatocele, varicocele, with the dilatation of the pampiniform plexus. And this is testicular torsion. As you can see, the high riding testis. The testis has It's a high-varying testis. Now, let's move down to testicular tumors. Okay. So testicular tumors, I'm going to talk about testicular tumors exactly how I talked about ovarian tumors. Okay. So before I do this, let me just draw the cross section of the testicles. So over here, testicular tumor, if we do a testicular tumor, then the testicular tumor consists of the seminiferous tubules and everything else. So how does it appear? If we do a coronal cross section of the testicular, if we do a coronal cross section of the testicles, and how do they appear? I already talked about this once. I'm going to talk about this one more time. Let's say that this is the testis, right? In the testis, you have the duct, right? And in the duct, you will only get developed sperms. So you have lobules like this. No, these are not lobules. These are cells. For example, spermatogoniums, spermatids, spermatozoons, right? So that's it. So these are all the cells. Do you guys remember I drew this once 2 days ago or something? I drew the same diagram. Do you guys remember that or not? Yes or no? Yes. Okay. What is the name that we gave for the cells that are tightly packed in between the spermatocytes? Sertoli cells. Very good. These are so tightly packed that you cannot differentiate each cell from one another. These are Sertoli cells. What are the names of the cells that stays outside and they stimulate the testes to produce testosterone? These cells, they are known as Leydig cells. Okay, that's that. Okay, good. So what happens is we get 2 types of tumors from the sperm. For example, in the ovaries, do you remember we got epithelial tumor, germ cell tumor, and sex cord stromal cell tumor? Yes or no? Epithelial tumor from the epithelium, germ cell tumor from the eggs, and stromal cell tumor from the stroma. Similarly, if the Sertoli and Leydig cells, if there's any tumor of the Sertoli and the Leydig cells, then we will get Sertoli Leydig cell tumor. Or we call this sex cord stromal cell tumor. Same thing. If we get, for example, if we had tumors arising from the egg of the ovum, what name did we give for that tumor? Fast answers, please. We gave the name germ cell tumor. Similarly, if we have tumors arising from the developing immature spermatocytes, can we also call them germ cell tumors? Yes or no? The answer is yes, right? So that's it. Now, over here, let's talk about the tumors and let's talk about them if they're germ cells or not germ cells. Okay. So testicular tumors, let's talk about them on the basis of 2 things, not benign or malignant. We'll talk about the tumors on the basis of if they're germ cell tumors or non-germ cell tumors. Okay. Now, the interesting fact is most of the tumors that will arise from the germ cell tumors, mostly all of the tumors are malignant. Have I made myself clear? Yes or no? Most of the germ cell tumors, they will be malignant. Let's talk about the first germ cell tumor. The first germ cell tumor that I want to talk about is that this tumor is very common in young adults, right? Especially you will have patients who will come to you. For example, just as how females conduct breast examinations, self-breast examinations, do males conduct self-testicular examinations? Yes or no? The answer is yes, right? So there will be a male who will come to you because they have noticed a growth in their scrotum when they were conducting a self-testicular examination. And when they come to the physician, they have a painless enlargement of one of the testes. And when they have a painless enlargement of one of the testes, especially if it's a young male and there is no pain. For example, when it comes to testes, having pain is good or not good? The answer is having pain is good, because if we have pain in the testes, then that is a sign of inflammation. If we do not have pain in the testes and there is a rock hard swelling, then that's not a very good sign. So whenever they come to us with this sort of presentation, when we do a biopsy for this tumor, we find this structure, a very similar structure that was found earlier in an ovarian tumor. This is a fried egg appearance. In ovarian tumor, we found this in which one? We found this in dysgerminoma, right? For males, if we see something like this is seminoma. Have I made myself clear? Yes or no? Seminoma. They are known as seminoma. And whenever we see seminoma, we would like to do placental ALP, placental alkaline phosphatase. Since it's a germ cell tumor, placental alkaline phosphatase for seminoma is actually very high. Okay, and the good news is that if we have a seminoma, we can try addressing the seminoma with radiotherapy, because seminoma is one of the most radiosensitive tumors there are. Okay, have I made myself clear? Yes or no? Okay, good. Now, yesterday, we talked about a type of tumor that has cells that resembles glomeruli. Well, what was the name of that tumor? Or what was the name of that cellular body? Did we call them Schiller-Duval bodies? Yes or no? Schiller-Duval bodies? The answer is yes, right? Schiller-Duval bodies. In which type of tumors do we see Schiller-Duval bodies? We see them in yolk sac tumor. So in males, there's also another sort of a tumor that the males present to you with. They present to you with a tumor that is hard swelling, right? A hard swelling, and usually the patient profile is less than 3 years of age. Since it's an endodermal tumor, especially endodermal tumors are very common in a very young age. So the age of the patient will be less than 3, right? And when we do a biopsy, we will find cells that look like this. These are called Schiller-Duval bodies. What is the name of this tumor? This is called endodermal sinus or yolk sac tumors. Have I made myself clear? Yes or no? Okay. Okay, good. Now we're done with 2. There's another one which should be highly familiar with all of you. This tumor arises from the germ cell of the testis, and we know this because when we do a biopsy, the patient comes to us. Because in biopsy, when the patient comes to us, they come to us with a growth, and we do a biopsy and we see tissues that are arising from all the 3 germ layers. What is the name of this tumor? This is a teratoma. Okay, this is a mature teratoma. Now the thing is, teratomas in females, are they malignant? Yes or no? Especially immature teratoma. The answer is yes. In females, are they malignant? Yes or no? Okay, the answer is yes. The thing is that in females, mature cystic teratoma was benign. Yes or no? Fast answers, please. The answer is yes. But in males, if we get mature teratomas, then in males, mature teratomas are malignant. Just the exact opposite. And immature teratomas in females are malignant, but in males, they could be benign. Have I made myself clear? Yes or no? Yes? Yes, males are always opposite. Yes, males are always opposite. Okay, good. Next one that I want to talk about is another sort of a tumor which you are very familiar with. This tumor is due to disorganized growth of the syncytial and the sagittal trophoblast. What is the name of this tumor? This is known as a choriocarcinoma. Okay. Can we expect these patients to have high HCG? Yes or no? The answer is yes. If HCG is high, then can we also expect these patients to have signs, symptoms of hyperthyroidism? Yes or no? Signs, symptoms of hyperthyroid. Why? Because the alpha subunit of HCG is identical to FSH, LH, and TSH. Okay. Okay. I just saw a student in the chat box who said positive pregnancy test. Okay. Good. Let me tell you something. There's a very high yield question where you have a male patient, by mistake, the pregnancy test for the male patient came back positive. Okay. And if you ever see a question like this in your step 1 exam, can you expect these type of males to have choriocarcinomas? Yes or no? The answer is The answer is yes. Okay. So next time, if any of your male friends ask you, if I do a pregnancy test, will it ever come back positive? The answer is yes. If you have a choriocarcinoma, then if you do a pregnancy test, it will actually come back positive. As simple as that. Okay. So we talked about 4 types of carcinomas, right? The first one is a fried egg cell. What is your diagnosis? Seminoma. The second one is a Schiller-Duval body. What is your diagnosis? Endodermal yolk sac tumor. The third one has layers from all the germ layers, teratoma. The fourth one has high HCG and syncyto and cytotrophoblast proliferation. This is choriocarcinoma. The last one is something which you are not aware of. Okay, this one is something that you are not aware of. This is called embryonal carcinoma. Embryonal carcinoma of the testis. Embryonal carcinoma of the testis is a very aggressive tumor of the testis. It is associated with increased HCG2, also increased HCG. And the thing with embryonal carcinoma is that they're so aggressive and they're so highly graded tumors that they cause severe necrosis of the testis. And patients will come to you with painful, hemorrhagic, or a necrotic mass. So it's very easy to diagnose embryonal carcinoma because most of the testicular tumors are painless and they're non-hemorrhagic, non-necrotic. That if you ever see a patient who comes to you with a painful, hemorrhagic, necrotic mass, right, along with this HCG is high, right, and like all of these things, your diagnosis should be embryonal carcinoma. Have I made myself clear? Yes or no? Yes. Okay, good. Now, if we have a patient who has non-germ cell tumors, then can we expect them to have 2 types of tumors? Yes or no? Number one is a Sertoli cell tumor. Next one is a Leydig cell tumor. Yes. Now, in both of these tumors, Sertoli cell tumors and Leydig cell tumors, can we expect to have high androgenic secretions? Yes or no? The answer is yes, right? The difference is that in females, Sertoli and Leydig cell tumors could be, for example, granulosa cell tumor is a malignant tumor. In males, hormone-producing tumors are not really malignant. They're mostly benign, right? So for example, if you ever see a question where you see a patient who has precocious puberty, right? A male patient who has precocious puberty, should you check if it's a central precocious puberty or a peripheral precocious puberty? Yes or no? The answer is yes, right? So what do we mean by central? When we say central, that means that there's excessive secretion of GnRH, FSH-LH, and that's how we have testosterone. But if there is a patient who has a testicular tumor, such as a Sertoli and Leydig cell tumor, can they have excessive peripheral or production of the testis? I mean, of the testicular hormone? The answer is yes. In that case, what would happen to the FSH and LH? Will it be high or will it be low? The answer is they will be low, right? So that's how you differentiate between central and peripheral causes of precocious puberty. So non-germ cell tumors, we have Sertoli cell tumor, we have Leydig cell tumor. In these cases, we can get excessive amount of testosterone. And when excessive amount of testosterone is not used, the extra testosterone will be converted to what? Fast answers, please. The extra testosterone will be converted to not DHT, estrogen. So can we expect these patients to have gynecomastia, palmarerythema, spider angioma? The answer is yes. Another sort of a testicular tumor that arises primarily in the testis is a testicular lymphoma. Okay, testicular lymphoma is a common testicular cancer, and we see this in very old men, especially above 50 years. Are we clear? Yes or no? Yes. Okay. Okay. Now, if we have a patient who has a seminoma, will they have high placental alkaline phosphatase? Yes or no? The answer is yes. Okay. If we have a yolk sac tumor is also a germ cell tumor. Yolk sac tumor, we will get high alpha fetoprotein. Please remember that. And choriocarcinoma, we will get high HCG. If you remember this, then this will be really easy for you. So in seminoma, placental alkaline phosphatase is high. AFP is low, AFP and HCG is normal. In yolk sac tumor, AFP is high, and placental alkaline phosphatase and HCG is normal. In in chorionic carcinoma, HCG is high, and AFP and PALP, they are normal. Have I made myself clear? Yes or no? Okay. Are we clear? Okay. Good. So that's it. Today, can we keep the lecture up to here? Yes or no? Fast answers, please. Tomorrow we will finish the reproductive system. And let's keep the lecture up to here. So before we move on to MBOS, can we do a quick revision and recapitulation of what we have studied? Yes or no? Sertoli cells also produce hormones. Yes, they also produce hormones. They produce inhibin. Okay, good. Okay, so let's do a couple of quick questions very easily. Number one, if you have a patient with a breast lesion, small, mobile, uniform, unilateral, single in number, very mobile, what is your diagnosis? Very good. Bilateral, nodular, multiple, what is your diagnosis? Very good. Leaf-like lobulations. Leaf-like lobulations, what is your diagnosis for the lesion? Very good. If you have another tumor that has microcalcifications arising from the terminal duct, what is your diagnosis? Very good. If we have a patient who has nipple retraction and skin retraction, is it due to Cooper's ligament or dermal lymphatics? Cooper's ligament. Very good. If you have a patient who has a cryptorchidism, is there a possibility they can get testicular cancer and infertility? Yes or no? The answer is yes. If you see a patient who comes to your clinic with severe lower abdominal pain, high writhing testes, with a history of being involved in a sport, fever, vomiting, what is your diagnosis? Very good. If you have another patient who comes to you with a bag of worms in their scrotum, this is non-transilluminative. This is very good. So if you ever see a patient who comes to you with a severe swelling of the testes, that is transillumination is positive, the patient is a really young patient, this is hydrocele. If you see a patient who has a testicular mass, you do a biopsy and you see fried axil appearance. So what is your diagnosis? Seminoma. What if you see a patient who has a testicular mass and you do a biopsy and you find ectodermal, mesodermal, and endodermal structures? This is teratoma. Mature teratoma in males is malignant or benign? Mature teratoma in male is malignant or benign? Malignant. If you see another patient with a testicular tumor and you see cells resembling glomeruli, what is your diagnosis? Yolk sac tumor. Very good. Okay. In seminoma, which hormone is increasing? The placental? ALP. Very good. In yolk sac tumor, which hormone is increased? AFP. In embryonal carcinoma, in choriocarcinoma, which one is increased? HCG. If you see a tumor in the testicles, which is associated with testicular necrosis, hemorrhage, what is your diagnosis? Embryonal carcinoma. So are we happy with how much we have studied today? Yes or no? Yes. Are we happy, or do we want to continue doing some more pages? Because I personally feel that we can finish the reproductive system tomorrow. But if you guys want to finish more pages, then we can. Can I get some feedbacks, please, from the students? Do you guys want to do questions or first aid? Which one? Questions or first aid? Question bank or first aid? Which one? Questions. Okay. Give me 1 second. Yes, please unmute yourself and ask me the question, please. Dr. BK, what question do you have?
Yes, doctor. I read somewhere biopsy is contraindicated for testicular tumor. Is it true, or we can do the biopsy to confirm the which type of tumor?
Biopsy is contraindicated. I'm going to tell you what sort of biopsy is contraindicated. You cannot
Okay.
take a small piece of the tissue. Okay. If you
Okay.
have to take a biopsy, then it has to be the entire organ. I mean, the entire tissue, meaning that you cannot just take a small piece of the testis, because if you do, and if it's a tumor, then there will be seeding. If needed,
Okay.
you have to do a biopsy of the entire testis and remove the organ by itself.
Okay. Thank
Good
you.
question. Very, very good question. Okay. Does anyone else have any questions? Yes or no? Dr. Alam, what question do you have?
Hello everyone. Actually, some of my friends want to join the class, and today, because I didn't receive any email
Which class?
early,
This one or
any of them. One of them just joined the class right now, and unfortunately the class has finished already. So she wanted to check if she is able to continue or not.
okay. Let me tell you something. Dr. Alam, the students, do they want to join the class in the morning or the one in the evening?
She just wanted to see if it is
Okay.
Useful in the morning. She will continue the morning and
Okay.
also afternoon. It depends. So she
Okay.
is now here.
She's here. Where is she? What's her name?
Aqsa.
Aqsa Suleiman.
Yeah.
Okay. Thank you so much for
I'm sorry
joining the
that I
class,
sent
Dr.
the link.
Suleiman. Okay, great. Dr. Alam, let me help you. First and foremost, whoever wants to join, all your friends, please ask them to send me an email to this email address. And what I will do is I will give them free recordings of the class so that they can watch the recording and get back to me so that tomorrow I can share the links of tomorrow's class with them. And also, I will be sharing the link for the evening class on emails and also in my Facebook page. So if any of your friends wants to come and join the class, please ask them to click the link on the Facebook page. What is the Facebook page? The Facebook page is this one. This is www.facebook.com/masteringfa. Okay, so if you go here, then you will see that I share all the evening batch links. Since they are free, everyone is welcome to join. Okay, is that clear, Dr. Alam? Yes or no? Dr. Alam?
Yeah, actually, she might be in favor of continuing in the morning class too.
Okay.
So that's why I asked her to see if it is still useful, because some of the lectures are already missed. If she can continue for
if
the
she can continue the morning classes, no problem. If she has missed out on the lectures, I will make sure that I give her the recordings so that she is up to date. Okay, absolutely no problem.
Yeah, and then actually, I'm sorry because I sent the link of today's lecture to her so that she can join and see the class. And I have other friends too that I'm gonna ask them to come. Just I was not sure about the timing of the class, and also I didn't receive the link today in my email, unfortunately. And this class doesn't have any link in Facebook group, so I was kind of confused if we have any class today or not. That's why I also came late.
Oh, makes sense. Yeah. Okay, I'm not really sure why you did not receive your email. Let me see. Let me see why. I sent out the email myself. Let me see why. This is your email address, Dr. Alam? Yes. Okay. So I sent you the mail. I'm not really sure why you did not receive it. I sent the email at 10 a.m. today. So that's it. Okay, no problem. So whoever of your friends wants to come and join the class, please share my email address with them and I will give them the link directly. Okay, thank you so much for helping us out, Dr. Alam. Who else has any questions? Does anyone else have any questions? Yes, what question do you have? Please unmute me. Please unmute and ask the question.
Excuse me, I wrote it in the chat box. I wanted the link of yesterday's class for CVS. I was.
Oh, for CVS? Oh, you weren't there? Okay.
I'm sorry, I didn't. I couldn't open my Facebook.
Oh, you can open your Facebook. Okay, no problem. Okay, please download this right away. Any other question? Okay. Is everyone ready to begin the amboss? Yes or no? Is everyone ready to begin the amboss? Yes. Can I get reproductive lecture 1 to 3? Yes, please send us an email and we will get back to you. For now, we don't have a lot of time. For now, let me begin the questions. Is everyone ready? Yes. Okay, so I need you to be ready with a pen and a paper. This will be a 15-question segment. How much time will you guys get for each question? Fast answers. How much time will you guys get for each question? Fast answers, please. 90 seconds. Okay. So one last time before I begin the test, is everyone ready or not? Yes or no? Yes, Dr. Rahimi, Dr. Singh, Dr. Hagar, Dr. Alam, Dr. Mohammed, Dr. Sana, everyone else? Dr. Tasneem, Dr. VK. Okay, let's begin. Best of luck. Hope you guys do a good exam. I will explain each and every question after we are done after 15 minutes. Okay, so thank you so much. Give me 1 second.
Hello.
Can you guys see my screen, the amboss screen? Yes or no? Yes? Okay. Best of luck. Let's begin. You have 90 seconds for each question. I'll explain the questions. Thank you so much. Okay, your time is up. Can everyone hear my voice? Yes or no? Your time is up. Can everyone hear my voice? Okay, so let's start with the first question over here very quickly. Can I get it? Okay, so let me read the question for you guys. Without treatment, this patient is at greatest risk for which of the following? 28-year-old woman comes to the physician because she has not had a menstrual period for 3 months. Okay, so amenorrhea for 3 months. Menarche, meaning the onset of menstruation, was at 12 years, and menses occurred at 30-day interval. She became irregular 1 year ago. She has okay, so BMI is a little bit high. Physical examination shows nodules and pustules along the jawline and dark hair growth. This is very easy, normal size uterus. What is the diagnosis for this one? Fast answers, please. What is the diagnosis for this one? PCOS, very good. But over here, you do not have PCOS. Without treatment, this patient is at greatest risk of developing what from PCOS? Endometrial carcinoma, very good. Let's move on to question number 2. So question number 2 over here, the last line says that the patient is at increased risk of developing which of the following complications? So patient comes to you at the 3rd trimester because of headache. She has vaginal delivery, does not smoke. She has preeclampsia, right? With preeclampsia, what is the most common complication? It's not placenta previa, it's not abortion, it's not rupture, it's abruptio placenta. Very good. Okay, good job. A disorder of which of the following structures is most likely the patient's condition? 35-year-old man, penile pain, especially on erection. Penis curves downwards and does not erect. He feels embarrassed. He was sexually active with multiple female partners with a palpable plaque. So this is Peyronie's disease, right? In Peyronie's disease, where do we get the fibrous plaque? We get the fibrous plaque in. Fast answers, please. Where? In the Dartos fascia, yes or no? The answer is no. In tunica albuginea, yes or no? The answer is yes. Okay. Okay, good. So we just talked about this. Without appropriate treatment, the patient is at greatest risk of developing which of the following complications. Over here, it's a girl, cramping, abdominal pain, blood pressure is high, high arch palate with maloccluded teeth, broad chest. Okay, so this is a child of Turner syndrome. Without appropriate treatment, the patient is at greatest risk of which one? In Turner syndrome, we have low estrogen level. Estrogen level is really low. So over here, for estrogen, low estrogen level, which one will we get? Osteoporosis. Very good. Very easy. Next one is you have which of the following additional findings is most likely in this patient? So a 22-year-old man comes to the physician for evaluation of a 2-day history of right testicular pain. He was treated for hypospadiasis and cryptorchidism. So he has a history of cryptorchidism. There's a rubbery, large right testicle. Orchidectomy is performed. A photomicrograph is shown over here of the mass. Do you see fried egg cells over here? Yes or no? Do you see fried egg cells over here? Which of the following additional findings is most likely in this patient? Do you see fried egg cells? No. Where do you see fried egg cells? Because I do not see fried egg cells. Where do you see fried egg cells? These, do they appear as fried eggs? Yes or no? Okay. So this patient, does he have a testicular tumor? Yes or no? The answer is yes. Okay. Now over here, this patient has a testicular tumor, and this patient has tissue that looks like this. Okay. Now over here, what do we see? Do we see that you have the seminiferous tubules, right? You have the seminiferous tubules like this, and surrounding the seminiferous tubules, do you have growth in the stroma? Yes or no? Do you have growth in the stroma, as you can see, right? These are the growths, and these are the seminiferous tubules. Can this be Sertoli cell tumor, just in case? Yes or no? Can this be Sertoli cell tumor? The answer is yes or no? Okay. So over here, this is a Sertoli cell tumor. This is a very difficult question. This is a Sertoli cell tumor, and what happens is that over here with Sertoli cell tumors, you get increased amount of estrogen. If you get increased amount of estrogen with Sertoli tumor, which one of these A, B, C, D, E's will be the correct answer? Fast answers, please. The answer is Which one of this will be the correct answer? Fast answers, please. With circular tumors and increased estrogen? The answer is E. Very good. Okay. That's that. Okay, this one. The next one. These abnormal cells are homologous to which of the following cells in females? Okay. 3-month history of facial growth. Serum shows elevated testosterone level. Left-sided mass. Resected mass shows pale testosterone positive staining cells with cytoplasmic rinky crystal inclusions. Okay, which one of this is the most common answer? So if you have cells that are producing rinky crystal, are they Leydig cells? Yes or no? The answer is yes. Which one of the following are the similar as Leydig cells? Leydig cells work with luteinizing hormone. Luteinizing hormone also works in which of these cells? Granulosa cells, Theca cells, Sertoli cells. Which one? Which one of this is the correct answer? We do not have a lot of time. Thank you so much. The correct answer for this one is Theca internal cells. Why? Okay, why? Because, okay, the correct answer for this one is Theca internal cells because they're testosterone positive, and Leydig cells also work in the luteinizing hormone works with Leydig cells, and luteinizing hormone works in the Theca cells. So that's why Theca cells are the correct answer. Okay, next one. The malignant cells from the lesion are most likely to drain into which of the following? Pap smear shows atypical squamous cells. Direct biopsy of the cervix shows evidence of squamous cell carcinoma. Where does the cervix drain? Fast answers, please. The cervix drains in, very good. Cervix drains in the internal iliac. Very good. B. Good job. Which of the following is the most likely? Okay, very good. This one, I just want to talk about this very quickly. Where does, what drains in the para-umbilical? We get stomach carcinoma. Supraclavicular, we get stomach carcinoma. Inferior mesenteric, we can get anything from basically the GI carcinoma to all the other ones. In the superficial lymph node, what drains? We get perineal cancer, vulvar cancer, right? And the distal 1/3. Left supraclavicular lymph node is known as the Burkos triad, right? Where we get sentinel lymph nodes for gastric cancer, ovarian cancer, and all of those. So internal iliac is the correct answer for this one. Okay, so that's it. Let me just save this image and share this with you guys over here. Okay, this one, number 8. Is everyone ready? Yes or no? Which of the following is the most likely diagnosis? 46-year-old woman with HIV, common because of 1-month history prior to the onset. Her menses were regular. She's sexually active. Current medications include OCP. Complication from the biopsy is shown. Which one of this is the correct answer? Do you see glands over here? Yes or no? Do you see glands secreting mucus? Okay. Is this squamous cell carcinoma? The answer is yes or no. Is this squamous cell carcinoma or not? No. Because if it was squamous cell carcinoma, then shouldn't we have seen keratin pearls and intercellular bridges? The answer is yes, right? This is adenocarcinoma. So invasive adenocarcinoma of the cervix. This is the correct answer. Okay. Are we clear? Yes or no? Okay. Number 9. Further evaluation of this patient's vaginal discharge is most likely due to which of the following findings? 23-year-old woman comes to the physician because of vaginal discharge. She has been active. There's no erythema. pH is high. Adding potassium hydroxide produces a fishy odor. This is which one? Bacterial vaginosis or Trichomonas vaginalis, or is it a yeast infection? This is Gardnerella vaginalis. Gardnerella vaginalis is a gram variable rod. Okay, very good. By the way, if it's Gardnerella vaginalis, do we get clue cells? Yes or no? Clue cells? The answer is yes. What are clue cells? Clue cells are cells of the vagina that consist of the Gardnerella organism on the lining. In the center, you have a nucleus. This is called a clue cell. I'll talk about this in details later. Okay, this one. Which of the following is the most likely diagnosis? 17 weeks gestation, physical examination shows dense breast, 2.5 centimeter rubbery mobile mass that is non-tender. Biopsy shows rounded contour with overgrowth of fibrous and glandular tissue. Which one of this is the correct answer? Fast answers, please. This is a single mobile mass. Single mobile mass. Which one of this is the correct answer? Fibroadenoma. Very good. Which of the following characteristic applies to the most appropriate pharmacotherapy? 46-year-old premenopausal woman undergoes lumpectomy. Breast cancer cells stain positive for estrogen and progesterone receptor and negative for HER2. Which of the following applies to the most appropriate therapy? Over here. So they're ER/PR positive, but that's it. So which one do we give? Fast answers, please. Since they're ER/PR positive, should we start with estrogen therapy? Yes or no? Should we start with estrogen therapy? Yes or no? The answer is yes. Okay. Estrogen agonist. Okay, next one. Pelvic ultrasound shows ovaries with multiple cysts and then normal uterus. Which of the following is the most likely diagnosis? 17-year-old girl is brought to the physician because she has not had her menstrual period. The mother reported that during her pregnancy, she noticed abnormal hair. Oh, this is very easy, right? This is which one? Fast answers, please. This is PCOS or aromatase deficiency. This is aromatase deficiency. So the questions that we are doing right now, do they go with our lectures? Yes or no? Yes. Fast answers, please. Yes. Our lectures, are they helping you understand the questions a little bit better? Yes or no? Okay. Yes. The actual Usmle step 1 exam, is it like MBOS or easier than MBOS? Easier than MBOS, much easier than MBOS. Okay. This one, number 13. A patient in mutation is most likely to have which of the following findings? Testicular cells includes a mutation that selectively impairs Leydig cell function. If Leydig cell is not functioning properly, then which hormone will be decreased or increased? Can we have decrease of testosterone? Yes or no? The answer is yes. What will happen to the luteinizing hormone? Will it be increased? Yes or no? The answer is yes. FSH and inhibin, will it stay normal? The answer is FSH and inhibin, will it stay normal? The answer is yes. So which one of this is the correct answer? E. Okay, next one. Which of the following is the most likely cause of the breast swelling? 34-year-old woman, lump in her breast. She was discharged from the hospital. Her medication is an OCP, 2.5 centimeter non-tender mass. Circumcised radiolution with a rim of peripheral calcification. Ooh, calcification is there. Okay, calcification is there. Which one of this is the correct one? Okay, but she has, circumcised lesion with a rim of peripheral calcification. Look, peripheral calcification is common in which type of disease of the breast? I told you this. Do you remember I said lateral lesions are more common in fat necrosis? Yes or no? Lateral lesions are more common in fat necrosis? Yes. So which one of this is the correct answer? I think this is fat necrosis. I'm not sure. If it is fat necrosis, then which one of this will be the correct answer? Over here, do you see fat globules? Yes or no? Do you see the fat globules? Over here, the answer is yes. So E is the correct answer. Cytoplasmic triglycerides will be released. Okay, next one. Which of the following is the most likely underlying cause of the patient's symptoms? Okay, so over here, 32-year-old woman comes to the physician because she has been unable to conceive. The patient reports monthly episodes of back pain, diarrhea. Oh, this is easy, isn't it? Back pain, diarrhea, and the pain occurs on a monthly basis. This is which one? Back pain, diarrhea, pain occurs on a monthly basis. Okay. Pelvic and rectal examination shows no other issues. This is not PID. She has monthly pain in her back and monthly diarrhea. If endometrial tissues are deposited in the GI tract, can we have monthly pain and bleeding and diarrhea? Yes or no? The answer is yes. Which one of this is the correct answer? A, B, C, D, E? A. Very good. Okay, good job, you guys. Thank you so much. Oh, so now, did we understand the questions for today? Yes or no? Did we understand the question for today? Yes or no? Yes. Okay. How many of us scored above 6? not 6. Let's say 8. How many of us scored above 8? Okay, very good. Very good. 8 is good. Okay, good. So thank you so much. Congratulations are in order for all the students who have answered so beautifully. Everyone else, can we ask you guys to revise, keep on revising the first aid, yes or no? Yes. Okay. Can you repeat question 2? Question 2 is about Leydig cells. Question 2 is about Leydig cells. Leydig cells, they're cells that have rinky crystal inclusions. I'll talk about this in details tomorrow. Okay, but for today, it's 2 p.m. The class timing is almost over, so I want to end the class over here. My last question to you guys is: did you guys enjoy the lecture? Yes or no? Fast answers, please. Okay. Did you guys understand the lecture? Yes or no? Fast answers, please. Okay, good. So thank you so much. I hope you guys have a very good day. Tomorrow, our class is the last class of this week, where we will finish the reproductive system, We will start the class at 10 a.m. So thank you so much. Hope you guys have a great day. I'll see you guys tomorrow at 10 a.m. If you guys have any questions, send us an email. If you guys have friends who wants to come and join the lecture, share our email address. Okay. And if you have any questions, again, send us an email and we'll get back to you. Okay. So best of luck. God bless you and bye-bye.